that in a high stakes medical emergency with a patient clinging to his life, the most critical clues aren't visible to the naked eye. They are microscopic, they are biochemical. Imagine a young man, let's call him Rohan, just 32 years old, a software engineer from Bangalore. He collapses at his desk, clutching his chest, a sharp, crushing pain radiating down his arm. Every second, his heart muscle is dying. The ECG is equivocal, the physical exam unhelpful. Doctors are scrambling. What's that one thing that can instantly tell them if Rohan is having a life threatening heart attack or just a severe panic attack? What's the secret language his heart speaks when it's in distress? By the end of this thrilling video, you won't just know the answer, you'll understand the intricate biochemical dance that saves lives. You'll be able to interpret these cardiac biomarkers. These aren't just lab values, they are the heart's distress signals, molecular messengers screaming for help. Mastering this isn't just about passing an exam, it's about separating the average doctor from the truly exceptional, the ones who make the right call when life hangs in the balance. This is where biochemistry becomes life saving medicine. Alright, let's uncover our first clue, the heart. That tireless pump demands an enormous constant supply of oxygen and nutrients. It works without pause, contracting over 100,000 times a day. But what happens when that supply chain breaks down? When a crucial coronary artery, perhaps blocked by a blood clot, starves a section of heart muscle. This deprivation is called ischemia. Think of it like cutting off the oxygen supply to a city. Lights flicker, systems fail. If this ischemia persists, the heart muscle cells, the cardiomyocytes, begin to die. This is irreversible cell death, and it's called necrosis. This brings us to the ultimate culprit we are hunting, a myocardial infarction, or MI, commonly known as a heart attack. It's a catastrophic event. But here's the breakthrough. When heart cells die, their perfectly sealed membranes, the sarcolemma, rupture. They spill their precious internal contents into the bloodstream. These spilled contents are basically our cardiac biomarkers. They are the silent witnesses, the molecular breadcrumbs left behind by cellular destruction. What do you think would be the ideal properties of such a biomarker? Imagine you are designing the perfect biochemical detective tool. You'd want it to be specific to the heart, right? Not just any muscle damage. You'd want it sensitive, detectable even with minor injury, and you'd want its levels to change. And you would want its levels to change predictably over time, like a ticking clock, telling you when the damage occurred. Congratulations. You've just mastered the foundational principles of cardiac biomarker utility. This understanding is your first step towards becoming a diagnostic superhero. Now, here's where it gets really interesting. We are going to meet our key players. Picture this. Inside every single cardiomyocyte, there's an intricate microscopic world, a bustling city of proteins, enzymes, all working in perfect synchrony to make that heart beat. When this city is under attack, these specific players leak out. Our star witnesses, the gold standard, is cardiac troponin. There are three subunits, TNC, TNI, and TNT. But here's the plot twist. Only cardiac isoforms, cTnI and cTnT, are uniquely specific to the heart. This specificity is their superpower. Why? Because they are integral components of the contractile machinery, the sarcomere. Imagine the sarcomere is a finely tuned engine built from thick myosin filaments and thin actin filaments. Tropomyosin coils around the actin like a safety belt. The troponin complex TNC, TNI, TNT is strategically placed on this tropomyosin. Muscle contraction is initiated by a sudden surge of calcium ions within the cell. This calcium acts like a key, binding specifically to troponin C. This binding isn't just a simple attachment, it causes a dramatic conformational change in the entire troponin complex. Think of it as a domino effect. This structural shift forces troponin I, which normally acts as an inhibitor, to release its grip on the actin filament. This in turn pulls tropomyosin away, exposing the myosin binding sites on the actin. With the coast clear, the myosin heads can now bind to actin, forming cross bridges. This binding is the trigger for the power stroke, where myosin pulls the actin filament, shortening the sarcomere and generating force. This entire energy intensive cycle requires constant ATP hydrolysis for myosin head detachment and recocking. So cTnI and cTnT are not enzymes, they are structural proteins tightly bound within this contractile apparatus. When a cardiomyocyte suffers ischemic damage and its outer membrane, sarcolemma, ruptures, these proteins, like precious cargo from a sunken ship, spill into the bloodstream. Their release is biphasic. A small cytosolic pool is released early within 3 to 6 hours, but the bulk, which is the structurally bound pool, continues to leak out for days, even weeks, providing a prolonged diagnostic window. This makes them incredibly sensitive and specific for even minor myocardial injury. Their prolonged elevation also offers a crucial clue about the timing and extent of the damage. For instance, a persistent elevation for over a week strongly suggests a significant and sustained myocardial insult. Next up, creatine kinase, or in short CK. While total CK can be elevated by any muscle damage, think a strenuous gym session or a bad fall, it's its specific isoform CKMB that acts as our next crucial clue for the heart. CK is an enzyme, a true workhorse in energy metabolism. The heart needs an instant energy reserve. It's like a high performance sports car needing a turbo boost. This is where the phosphocreatine shuttle comes into play. Catalyzed by creatine kinase, the enzyme facilitates the reversible transfer of a high energy phosphate group. When ATP is abundant, CK catalyzes the reaction ATP plus creatine, converting ATP plus creatine, forming ADP plus phosphocreatine. This stores energy in the form of phosphocreatine, but when ATP demand skyrockets, like during intense contraction or ischemia, and ADP levels rise, the reaction reverses. It becomes ADP plus phosphocreatine, giving ATP plus creatine. This rapid regeneration of ATP is critical for maintaining cellular energy homeostasis, especially when oxidative phosphorylation can't keep up. Without this buffering system, the heart's energy supply would be dangerously unstable. CK exists in three main dimeric forms, each a combination of M muscle and B brain subunits. CKMM predominant in skeletal muscle, CKBB predominant in brain, and CKMB a hybrid found predominantly in cardiac muscle, comprising about 20 to 40% of total CK in the heart. When myocardial injury occurs, this cytoplasmic enzyme CKMB leaks out. Its kinetics are generally faster than troponins, peaking earlier around 10-24 hours, but also clearing faster. This rapid rise and fall can be useful for detecting reinfarction. To enhance its cardiac specificity, we often calculate the CKMB relative index, which is CKMB mass divided by total CK activity into 100. A value greater than 2.5 to 3% strongly suggests cardiac origin. So, while not as specific as troponins, CKMB still offers valuable insights, especially in the very early hours or for monitoring therapeutic responses. Our rapid response agent, myoglobin, is a small heme containing protein. Think of it as the heart's tiny intracellular oxygen reserve tank. Its primary function is to store oxygen within muscle cells and facilitate oxygen diffusion from the cell membrane to the mitochondria, ready to deploy oxygen during sudden bursts of demand or transient ischemia. It's a it's similar to hemoglobin but has only one heme group and binds oxygen more tightly. Because of its relatively small size, around 17 kDa, and its cytoplasmic location, myoglobin is released very rapidly after myocardial injury, often within 1 to 2 hours, making it the earliest detectable biomarker. However, here's its Achilles heel: it lacks cardiac specificity. It's abundant in both cardiac and skeletal muscle. So while it can give you an incredibly early hint, it can't definitively diagnose a heart attack. A positive myoglobin just tells you some muscle somewhere has been damaged. But a negative myoglobin within the first few hours can be an excellent rule out marker. If myoglobin isn't elevated early on, it's highly unlikely significant myocardial injury has occurred. Finally, we meet the natriuretic peptides, specifically brain natriuretic peptide, and its inactive N-terminal fragment, NT-proBNP. These are not markers of acute myocardial damage, but rather sophisticated indicators of cardiac stress or strain. They are the heart's own hormonal response system, invaluable for diagnosing and managing heart failure. BNP is synthesized primarily in the ventricular cardiomyocytes as a precursor, proBNP. When the heart's ventricles are stretched due to increased volume or pressure overload, a hallmark of heart failure, proBNP is cleaved into two fragments: the biologically active BNP and the inactive but stable NT-proBNP. Both are then released into the circulation. Their physiological role is to counteract the determinal effects of fluid overload and vasoconstriction, which are common in heart failure. BNP acts as a hormone, binding to specific natriuretic peptide receptors on target cells in the kidneys, blood vessels, and brain. This binding activates guanylate cyclase, an enzyme that converts GTP into cyclic GMP, cGMP. cGMP, acting as a crucial secondary messenger, then triggers a cascade of beneficial effects. It causes vasodilation, which is relaxation of blood vessels, and reduces blood pressure. It promotes natriuresis, which is sodium excretion, and diuresis, which is water excretion by the kidneys, reducing circulating blood volume, and inhibits the renin angiotensin aldosterone system, or in short, the RAS system, further countering fluid retention and vasoconstriction. So, elevated BNP or NT-proBNP levels tell us that the heart is under significant strain, working harder than it should, often seen in heart failure. NT-proBNP is often preferred in clinical practice due to its longer half-life and greater stability in blood samples, making it a more reliable measurement. Understanding these peptides helps us differentiate cardiac from non-cardiac causes of shortness of breath, guiding timely and appropriate treatment for heart failure patients. Alright, let's put your newfound knowledge to the test on the wards of India. Case file 1. The Mumbai Marathon runner. Meet Rajesh, a 45-year-old software architect from Mumbai, usually fit, runs marathons. He presents to the ER with sudden crushing chest pain radiating to his left arm, accompanied by profuse sweating. ECG shows ST segment elevations in anterior leads, which is classic MI. His initial high sensitivity troponin T, is 150 nanograms per deciliter. The reference is less than 14 nanograms per deciliter. 2 hours later, it's 800 nanograms per deciliter. Now it's your turn. What's your next move? Okay. Given the classic symptoms, ECG changes, and rapidly rising cardiac troponin, Rajesh is having an acute ST elevation MI, or in short, STEMI. STEMI. Your immediate action could be to activate the cath lab for primary percutaneous coronary intervention, PCI, opening that blocked artery. You just saved Rajesh's life using cardiac troponins as your definitive diagnostic guide. Case file 2. The Chennai Granny's breathlessness. Now meet Meenakshi Amma, an 80-year-old from Chennai, known for her delicious filter coffee. She comes in with increasing shortness of breath, swelling in her legs, and fatigue over the past few weeks. No chest pain. Her ECG shows old changes but no acute ischemia. Her NT-proBNP is sky high at 7,500 picograms per ml. A reference is less than 300 picograms per ml for her age. What's your primary diagnostic suspicion here? Okay, while the symptoms could be many things, that dramatically elevated NT-proBNP screams heart failure. It tells us Meenakshi Amma's heart ventricles are severely stretched and under strain. You'd initiate treatment for acute decompensated heart failure, managing her fluid overload with diuretics and optimizing her cardiac medications. You just helped bring relief and clear diagnosis to Meenakshi Amma, all thanks to Natriuretic Peptides. Case file 3. The tricky trauma from Delhi. Finally meet Amit, a 28-year-old from Delhi, involved in a major road traffic accident. He has multiple fractures and severe muscle trauma. He complains of some chest discomfort, but it's hard to tell if it's from injuries or something else. His total CK is 15,000 units per deciliter. Normal is less than 200 units per deciliter. And his CKMB is 300 units per deciliter. His CKMB relative index is 2%. What's your interpretation? Is Amit having a heart attack? While both total CK and CKMB are elevated, the CKMB relative index of 2% is below the diagnostic threshold for cardiac injury, which is typically more than 2.5 to 3%. This suggests the high CKMB is primarily originating from the massive skeletal muscle trauma, not his heart. You'd monitor his troponins carefully, but you wouldn't jump to a heart attack diagnosis based solely on these CK values. This careful interpretation saved Amit from unnecessary cardiac interventions. Okay, now time for some mnemonics, which can be like your secret weapons for exam day and beyond. Here's a way to never forget this crucial information. Troponin's timing. Think of troponin as a thriller. It's the top marker, peaks 3 to 6 hours and stays high for 2 weeks. Troponin is your true guide for thrombosis. Okay, now the next one. CKMB's cricket game. CKMB is like a cricket match. It starts quickly, early rise, but it's quickly gone, fast clearance. You need the captain, total CK, and the batsman, which is CKMB, to know the match result, which is the index. The next one, the last one, BNP's Bollywood dance. BNP is for breathlessness, bloating, and big heart failure. Think of a big Bollywood dance with lots of fluid and swelling. It's the best for big heart problems. Now close your eyes. Can you recall all 3 mnemonic hooks? Good. These quick links will instantly trigger the full story. So a couple of questions for you. Okay, so it's like a quick fire round. Okay, your answers show how ready you are for tomorrow's rounds. No pressure, just pure biochemical brilliance. Question 1. A patient presents with acute chest pain. Which biomarker is the most specific for myocardial injury, even if present in very low concentrations? Myoglobin, total creatine kinase, cTnI, or BNP? The answer is C, cTnI. Its cardiac specificity makes it unparalleled. If you got this, you're ahead of 80% of your batch. Question 2. Which biomarker is primarily used to diagnose and monitor heart failure, reflecting ventricular wall stretch rather than acute wall necrosis? Option A, CKMB, B is myoglobin, C is cTnT, and D is NT-proBNP. The answer is D, NT-proBNP. Remember the Hollywood dance? It's all about the heart being under strain. Question 3. A patient comes in with severe leg muscle trauma. Their total CK is extremely high. To help differentiate if there's also cardiac involvement, which additional calculation or marker would be most helpful? A. Repeat total CK in 2 hours. B. Measure serum lactate dehydrogenase. C. Calculate the CKMB relative index. Or D. Measure serum potassium. Okay, so the answer is C. Calculate the CKMB relative index. This ratio helps us tease out the cardiac component from widespread skeletal muscle damage. Okay, finally coming to the summary. You have navigated the intricate world of cardiac biochemistry like seasoned detectives. So your cardiac biomarker superpowers are now unlocked. Cardiac troponins, your ultimate highly specific guide for acute MI, staying elevated for days. CKMB, your earlier though less specific indicator of myocardial damage, especially useful with the relative index. Myoglobin, your earliest rapid rule out marker despite its lack of specificity. Natriuretic peptides, BNP or NT-proBNP, your crucial tools for diagnosing and managing heart failure reflecting cardiac stress. And clinical context, the absolute necessity of integrating biomarker results with patient symptoms and ECG findings. Hope you enjoyed this class. Thank you for staying till the end and hope you learned a lot of new things. Thank you for watching. Hope to see you in the next one.